Okay. So thank you, Joyce. It's good to be here. Always good to be here with my friend Veronica. And we're going to give you an introduction today to Smart Recovery, which is a support group. And hopefully by the time we finish this short presentation, you'll understand the benefits of Smart Recovery and maybe even be interested in exploring that as part of your treatment in your clinic. I have no disclosures. So this is an introduction to SMART that I'm not going to click on, but I did include it here if you want to go back later and listen to this little video. But I'm going to start with what is SMART Recovery. Many of you may not be familiar with SMART. Most people are familiar with AA, NA, and others 12-step programs, but SMART is the second largest support group in the world. Actually, it's an international recovery organization. It's a science-based addiction recovery group. It seeks to empower individuals to take responsibility for their own recovery through everyday behavioral changes. It has its roots in rational recovery, which began to be popular in the 80s. And in 1994, Rational Recovery changed its name to Smart Recovery and has been operating or doing business as Smart Recovery ever since. SMART is different than other support groups, in particular 12 steps, in that SMART is all about individual choice. It works for all addictions. So a person can attend SMART if they have a substance use disorder or if they have a behavioral addiction. And we have people in SMART that have alcohol use disorders, opiate use disorders, stimulant use disorders, or they might have gambling addiction, pornography, gaming, those kinds of things. But the program works for all addictive behavior. SMART itself does not take a position on whether addiction is a disease. They've decided to stay out of that. It is also not a faith-based program, but it does allow for spiritual talk because whatever a person wants to talk about in SMART, as long as it's not bashing another recovery program, it's allowed. So it's not faith-based, but it's not anti-faith. In SMART, we do not have sponsors, so there's no sponsorship. And SMART does not require lifelong attendance. In SMART, we say you come as long as it's helpful to you, and you can go away and you can come back. We don't count days of sobriety. We don't give out chips. We don't stigmatize you if you don't attend on a regular basis. It's whatever works for you. And one of the reasons I have Veronica here is that I want her to speak to her firsthand experience as a person, as a CPRS, and the difference between being a member of SMART and a 12-step program.
Yeah, so, and I'm just going to explain because I never know who's new on here. Certified Peer Recovery Specialist is just somebody in long-term recovery that is recognized by the state of Tennessee. So my personal stance is, or for me, my personal recovery, I've always been in a 12-step program, NA or AA. And I will start with saying this about SMART and all groups is that they all have one thing in common, and that's the importance of connection and getting you connected to people and to other people in recovery. And I've had the pleasure to be introduced with Smart Recovery whenever I came just to do my internship as a social worker with Mina. And there's a lot of similarities, but a lot of differences. Smart, she did a wonderful job of showing to what the big things are that are different in the 12-step recovery. And I think the biggest one for me coming in and seeing the difference is more so my 12-step recovery is more so on experience tools given to me by just the experience of the members that have gone before me. And of course we have our steps, but this SMART is more formatted and giving you actual tools that is in a like just an ABC literally fashion. You'll see one of those shortly, but things that are actually they're educational things that you can actually pull out besides just trying to think of kind of on the top of your head. But like I said, I really appreciate the similarities on just the connection piece. And another big thing, and this is, if anybody's in recovery, they'll understand this, what crosstalk is. Crosstalk is allowed in Smart Recovery when it's not so much in the 12 steps, it's more on an individual sharing their experience. But Smart is more organic and people just talking back and forth based on their own experiences.
Thank you, Veronica.
Yeah.
I always appreciate Veronica's opinion as someone in recovery, and I like to run things by her and say, is this helpful? One of the benefits of SMART for a person like myself who is a provider but not in recovery is that I actually can lead a SMART recovery meeting, whereas in AA or 12-step programs, I would not qualify for leadership. And so it makes it accessible for providers who don't have their own history of substance use or behavioral addiction. So as Veronica said, SMART it provides a specific set of self-management tools and skills. And these are primarily based in cognitive behavioral therapy, which has a robust evidence base of effectiveness. SMART meetings are opportunities for fellowship, this is true, but to learn, practice, and refine these skills. And behavior change is the goal of SMART Recovery. SMART Recovery has a 4-point program instead of a 12-point program. The 4-point program doesn't go in order. These are things that you can work on throughout your recovery, but they are building and maintaining motivation for change, coping with urges, managing thoughts, feelings, and behaviors, and in particular, problem solving to manage those, and maintaining a lifestyle balance, which is short versus long-term satisfactions. And these 4 points are based in the stages of change theory. So you can sort of see the stage of pre-contemplation to contemplation. You might want to work the first step. And then if you're in maintenance, you would be working the 4th. But so this is sort of the basis of SMART Recovery's program. So stages of change are a big part of the program, as I said, and I'm sure we're all familiar with those, but I just wanted to put this slide up here. As you can see, contemplation, preparation, action, maintenance. Relapse is actually not a stage, it's just something that happens in recovery, and then it's not a stage itself. But the activities in SMART are matched to those stages. So in the first stage, when we're trying to motivate people in recovery, the SMART Recovery helps attendees simply understand the stage of change. And one of the things I love about SMART as an educator is that it really respects the intelligence and integrity of attendees. And I'd like you to say something about that a little bit, about how we provide a lot of information and education and respect the ability of SMART Recovery attendees to learn new things. And
yeah, definitely. I mean, because we all come in at different stages in our recovery, whether it be, it's still using or still, or just 60 days in or have years in, SMART Recovery definitely protects the integrity of more of, you don't really know what stage they are in unless they offer it up themselves. Mm-hmm. And I appreciate that, and as far as somebody that even is learning how to facilitate a SMART Recovery group, it helps as far as just to not put anybody on the spot. I really do appreciate that. It is more laid out again in a format, and they're with, and it's the same really for 12-step groups as well, that people can share their experience whether they want to or not. They don't have to. Mm-hmm. And SMART is just more of a detailed, and really it doesn't always just dig into the substance use, it digs into the behaviors. Mm-hmm. And I think that really helps to make people more comfortable, because if they're not ready to focus on their substance use, they can focus on something else. Yeah. And that whether it be a behavior or anything. So, and people can come to SMART Recovery even if they're in the pre-contemplation stage of change, and they are not ostracized because they're not ready to change yet. And a lot of patients, as we know from the theory of change, that if you push somebody, you can actually push them away from change. And so helping our attendees understand where they are in the cycle of change and normalizing that. Most of our patients really appreciate that attitude. SMART Recovery helps patients accept choice and personal responsibility. So unlike other recovery programs, we don't talk about being powerless. We talk about having a lot of power to affect change in your life. Another thing that helps motivate for change is accepting
is doing cost benefit analysis. So these are the three tools that we use in SMART. I'm going to move through this pretty quickly. In the early stages of change, to increase motivation, we present the stage of change wheel. We can do a cost benefit analysis, and then we have a change plan worksheet. So this is what a CBA looks like, and all students that work with me get very proficient at using a CBA, and this is a very good standalone intervention, even if you don't do SMART recovery groups, talking about the advantages or disadvantages of using or engaging a behavioral addiction, and then looking at the advantages and disadvantages of not. And so this is how we move people forward in terms of their motivation, is creating that discrepancy between the advantages and the disadvantages. Here's a change plan worksheet. So again, very structured. We might do one of these in a SMART recovery meeting as a group. An attendee might volunteer to identify change they want to make. It does not have to be related to their using or doing. It could be, I just want to exercise more. And so this change plan worksheet works for any change that an attendee might want to make. In SMART recovery meetings, there's a lot of what we call parallel processing, which means one person volunteers to speak to their experience and everyone else is processing their own experience right along with it. So the second part of the SMART recovery program is coping with urges and cravings. And so we spend a lot of time just understanding and normalizing urges, that they're a normal part of change. They're not catastrophes, that you can stand your urges. They do pass. They don't control your behavior. And the tools that we use for that are urge surfing or using mindfulness. In our recovery meeting here, SMART recovery meeting, we do mindfulness at the traditional sort of mindfulness meditation at the beginning of every SMART recovery meeting. So again, that's a tool that they can take with them. We teach attendees how to manage their urges, recognizing, correcting any thinking errors that they might have, and then naming and refusing urges. Here's a worksheet that we use if someone wants to work on managing urges, and it's called the DEADS worksheet. Deny, escape, avoid, distract, substitute. Again, this is a wonderful handout that you can use whether you have a SMART recovery meeting or not. All these tools are available. You do not have to be trained to use individual SMART recovery activities. Managing thoughts, feelings, and behaviors. This is a big one. This is the part of the program that helps prevent a return to use, because emotional upsets are generally the leading cause of relapse. So when we're looking at thoughts, feelings, and behaviors, we're again looking for irrational thoughts, identifying emotional triggers. Like good cognitive behavioral therapists, we're connecting the thoughts and the feelings to the behaviors that follow. And then we're helping develop improved coping skills. This is the ABCs of REBT is a problem-solving worksheet that is, if you're familiar with rational emotive behavior therapy, it comes from that. So if we have a person that comes in and has had something difficult happen in the week and they had a return to use, we would break it down for them. We would talk about the activating event. What happened? What did you do? The consequence of that. So I drank and I got into a fight with my partner. Then we look at the beliefs about the event. We're looking for irrational thinking. We're going to dispute the irrational thinking and then create an effective new belief. And after we finish that, we may engage in problem solving so that the activating event doesn't end up causing a return to use the next time. And so the fourth point in SMART recovery is maintaining lifestyle balance. This is actually my favorite part of SMART. And I think for a lot of our patients who also attend AA or NA and get value out of that, I think this is something that really sets SMART apart. And I know I'm putting you on the spot, but would you talk a little bit about how this is very different?
Sure.
Yeah.
So it's a lot of accountability, self-accountability, and that this really focuses on your complete lifestyle, from not just using, but, like she put in the PowerPoint, eat, sleeping, the way that you treat other people, the way that you, even to what, if you're making your bed in the morning, you know, I mean, this is, the difference for me, but it's honestly a lot of the same to me, as far as within the 12 steps, and the 12th step is to, you know, maintain your recovery.
That's
it
true.
really, you know, so it's really a lot similar, it just looks different and is worded very differently.
Right.
But the accountability, the way this is more different is to set your own SMART goals, and that's the sustainable, the, you know, the time friendly, those kind of goals, and being very goal oriented. To me, SMART is more goal oriented in the short term and in the long term. When for me doing my steps, I have my goals, but they were more shortened in early recovery. But now that I'm in longer recovery, my goals are just to kind of maintain homeostasis, right?
Yeah.
I mean, just how I am.
And I think the thing that's different about SMART is, even though you're right that certainly you're working the 12th step, you're working on lifestyle balance. We don't go in order. Like, you don't go from 1 to 2 to 3 to 4 in SMART. True. You start working on lifestyle balance in the very beginning, making those small accountable changes from the start. And as Veronica said, one of the ways we do that is that at every meeting we set SMART goals. So everyone leaves the meeting with one small behavior change that they're willing to be held accountable for. And oftentimes we'll use reminder cards where they write those down. Even though I'm not in recovery, I participate in the group as an attendee. And so, as Veronica mentioned, making a bed, my recent goal is to get back to making my bed on a regular basis. And so as a facilitator, I'm right there remembering how hard behavior change is. And how important accountability is. What about return to use? Well, just like in the theory of stages of change, that we know that return to use is a normal part of recovery. We expect our patients to have a return to use, and that return to use or lapses or relapses, or whatever you want to call them, slips, are not a reason that you have to start all over with the steps again, because you just come back and you get back on the horse and you keep riding it and you keep learning, using one of the tools of SMART to learn, why did that happen to me? How can I cope better next time? So it's really an opportunity to learn. And because we don't count days of sobriety, we don't remove chips, although that's effective for some people, sometimes that can be pretty demoralizing. So we don't do that in SMART, although members are welcome to count their own days of sobriety. But we recognize that change looks more like an upward spiral, where you're circling around those stages of change, moving forward, but cycling through those stages on a regular basis. So what does a SMART recovery meeting look like? They pretty much look the same all over the country. There's an opening statement or welcome, depending on whether there's a new person or not. In our SMART recovery meeting, we always start with mindfulness meditation. Some meetings end with it. Personal introductions. The meat of the meeting is the agenda setting. And so what we do is we go around the room and we ask who needs time on the floor, who had something happen this week that they want to share positive, or that they want to process that was a struggle for them. And generally those are issues in which there was an activating event, and the person wants help coping with them. So that's how we set the agenda. And if nobody has anything in particular they want, the facilitator always comes with one of the tools to work. In the community, SMART recovery meetings, pass the hat for a donation. In the clinic, we don't do that. But that is something that happens out in the community and other SMART recovery meetings. At the end, there's always homework or goal setting. What can you do this week that would help? And of course, a closing, and often meetings will end with a socializing. We have a 1-hour meeting here at the clinic, so we don't stick around too long, but sometimes they will spend a significant amount of time socializing. So just to review some key points, in SMART recovery, there are no experts. I am not an expert on your recovery. You are an expert on your recovery, and crosstalk among people is encouraged so that we can hear what's working for other people. There's no pressure in SMART. Participants make their own choices. This is not a pressure group. And some participants can simply sit back and listen. They don't have to participate. And that SMART is all about the tools. And these are tools that we teach and that can be practiced in real life situations. And they can be used in situations other than just recovery work. The SMART tools work for other things in life as well. So what does it look like in outpatient treatment? Well, what you can do if you are interested in SMART is you can, like I do, facilitate a traditional in-person SMART recovery meeting in your clinic. I know in Johnson City, High Point has a SMART recovery meeting that is run in their clinic. If you are going to run a traditional SMART recovery meeting, you do need to have facilitator training, which you can find information about on the SMART recovery site. You can refer your patients to an online SMART recovery meeting, and I'll tell you how to do that in just a little bit. You can use the SMART Recovery 4-point program as a basis for your own customized group curriculum. So even though we have a traditional SMART recovery meeting here on Monday evenings, we have a Wednesday group program, which from time to time we review the SMART Recovery 4 points because they're so helpful. You don't have to have facilitator training to use the ideas from the 4-point program or to use individual SMART tools. I love to use the cost benefit analysis, the change plan worksheet, and the values clarification as brief interventions in the clinic just as a behavioral health consultant. They work really well, and I think you've done that as well.
Oh, definitely.
Yeah.
Just even the CBA alone,
Yeah.
I use a lot.
Right. And so those are very accessible to peer recovery specialists. You don't have to have a master's to use these tools. So that's kind of a handy thing for a group. Here are some SMART Recovery online resources. The smartrecovery.org is the main site. There's also meeting locations. So one of the goals for today was that you would know how to refer someone to a SMART Recovery meeting. You just go to smartrecovery.org, go to the meeting, and it will show you all the meetings that are located in your area. I'm here in Johnson City. If you happen to be here, we do have 4 meetings. Our meeting here at the Family Practice Clinic is open, is considered a closed meeting. It's only open to family practice clients, but for those of our residents that are hanging in there, listening today, hanging out, please refer your patients to SMART Recovery. They don't have to be an addiction medicine patient to come to our SMART Recovery meeting on Mondays at 5:30. And here is a extensive SMART Recovery bibliography if you're interested in a deep dive into the research of the efficacy of SMART Recovery. Is there anything else that you'd like to add?
I think you nailed it. You did great.
Okay, that's all I have for today. If anyone has any questions, I'd be happy to answer them.
Thank you, Mina. That was a wonderful overview of SMART. Even though I live and breathe in the same clinical space as Mina, I needed that overview of SMART too to understand even more detail of the great work you guys do in here on Monday nights. And I've also pulled out that cost benefit analysis tool. It's a good one, the CBA. So I recommend using that as well in any setting that you're in, because it's useful when you're helping patients navigate what am I choosing to do when they look at you and they're like, what should I do? I'm like, I don't know. Why don't you tell me? And I'll get at the cost benefit analysis. It's more effective. Any questions for Mina? Well, if you have a question that comes up later, you know how to get us through ETSU Family Medicine. Reach out to Rebecca, our coordinator, and she can get you to Mina with any questions about that. I felt bad for calling on Suzanne to introduce herself when she was trying to get from one place to another. So I gave Chris a minute to settle down, and then I didn't ask you to introduce yourself, Chris. So Chris, if you could unmute and introduce, please.
Sure, thank you. Yeah, Chris Copeland. I'm an addictionologist at Revita Recovery in the Newport office. Well, we're glad to be here.
We're glad to have you, Chris. Sorry for skipping you before we went into the presentation, but I'm really glad you're here with us.
No problem.
Cool. All right, Aaron, are you ready with your case presentation?
Yes, so we had a little bit of difficulty tracking down the case that I submitted, so I'm just going to present what I remember and go from there, if that's all right.
That's perfect.
So I work in an inpatient hospital, primarily working on the psychiatric unit, but we also have a substance use and detoxification unit as well. So I wanted to talk about a patient who is currently on our recovery center unit. So he is a 30-year-old male patient who came to the emergency department a few weeks ago requesting detoxification from benzodiazepines and alcohol. So on further, when we acquired more information, we found that he was using up to 12 milligrams of Xanax daily, along with Klonopin and about a bottle of wine every night. So he had a past history of inpatient substance use treatment in 2017 that was mandated by court after a DWI. He also had a history of generalized anxiety disorder and had a trial of multiple different antidepressants, including SSRIs and SNRIs, all of which were unsuccessful and exacerbated his irritable bowel syndrome. So he began using Xanax, like I said, quite often and at high doses. And so he was admitted to the medical center for medically supervised detoxification. And then the plan was to transfer him to our inpatient detoxification unit and substance use unit. So I wanted to present him because I believe that managing benzodiazepine withdrawal on top of alcohol withdrawal can be very tricky. And I wanted to present a time where I don't think here at our hospital we did a great job, or there maybe are things that we could have done a little bit different. So after I believe 3 or 4 days on the medical unit where he was, or just the general medicine floor, he was receiving 2 milligrams of Ativan, I'd say every 4 to 6 hours. And so he was receiving that for 3 or 4 days, kind of in a gradual taper. And then after he completed that short taper, he was transferred to the recovery center. And around 4 o'clock in the evening on his first day of, first full day on the recovery center, after a day of participating in groups, he did not receive any benzodiazepine for detoxification at this time. And a rapid response was called as he had a grand mal seizure on the floor. So he was found, he fell face down, fell on his face, and when he came to, he was very disoriented, kind of unclear what was going on. So he was then transferred back to the medical floor after underwent a head CT, and I believe was connected to an EEG, and they determined that he had a withdrawal seizure. And then they went back and watched the videotape and witnessed a 30 to 45 second seizure. So after being transferred from the recovery center back to the medical unit, he was once again started on a Ativan taper. And he was seen by neurology, he was seen by a surgeon for the wound on his face. And he was started on levetiracetam or Keppra anticonvulsant, 500 milligrams twice a day, to continue for 2 weeks while he is coming through or dealing with the benzodiazepine and alcohol withdrawal. So after he finished that taper on the medical unit, which was for several days, he was transferred back to the recovery center and continued his Ativan taper. And so he's had several instances of taper. And I should highlight that he was using benzodiazepines at these high doses for an extended period of time. I spoke with him and he said that he'd been using benzos for over 7 years. So that long duration of use complicated the detoxification for sure. So he completed an Ativan taper once more on the recovery center, and then was actually transitioned into a phenobarbital taper, which is kind of interesting. And this whole case and trying to wean him off of benzodiazepines along with alcohol was just a very difficult. And he was continuing to show signs of, withdrawal even after all of these tapers. So currently he has just finished the phenobarbital taper and is now being prescribed Klonopin 0.5 milligrams as needed every 12 hours. And I think the goal for him would be to eventually come off of benzodiazepines, but he's had such a hard time doing that. There was a period earlier on in his treatment several years ago where he was successfully tapered off of benzodiazepines using Valium or diazepam. At this point in time, I believe his main triggers or issues that he's having in his life is just anxiety, which he was self-medicating with the benzodiazepines, but also he had lost a brother to opioid overdose in 2019. So there's significant stressors in his life. So currently, I guess we're just trying to get him to a point where he is no longer at risk of having seizures related to benzodiazepine withdrawal. So I wanted to share his case because I could use any tips that anyone has on successfully getting people off of benzos when there's concurrent alcohol use. Of course, if anyone has any questions.
I was actually going to ask for clarifying questions, but I was going to give just a really quick rundown of it. So you've got a 30-year-old gentleman who came in needing detoxification from alcohol and benzos, initially placed on the medicine floor, general medicine, got him started on an Ativan taper, 2 to 4 milligrams about every 6 hours, I think is what you told us. Finished that taper. It was a few days worth of taper, sent to the recovery unit, and then within 24 hours of being there, had a grand mal seizure related to withdrawal. Back to medicine floor, back on some Ativan, longer taper, back to the recovery center, where finishing that taper, went on some phenobarbital, and is now getting a little bit of Klonopin, but he has the complications of generalized anxiety, and it sounds like grief with losing his brother. So that is an amazing case, Erin. There's a lot there. There's so much good, yummy stuff there. This poor man's unfortunate experience. So thank you for bringing this case to us. Does anyone have any clarifying questions for Erin?
I have a question. This case didn't go to the mortality M&M kind of the evaluation to change their way of treating the patient at the hospital.
It's a really good point. I don't think it's gotten that far yet. I mean, it's something that, I think is worthy of it. I went to the code and, I went back and reviewed the EHR and I saw that, man, this was a pretty short Ativan taper. And I'm not sure if it had something to do with just transitioning from different units into the hospital that an order didn't get placed. But yeah, it definitely, with that much benzodiazepine use and over that many years, I think it was much too quick. So I haven't heard any follow-up, but I think it could be easily justified.
This is Dr.
Others?
I have
Yes.
a clarifying question as well.
Mhm.
I was wondering if you could elaborate on the phenobarb taper. What was the dose of the phenobarb that was used, and what was your titration point? For what length of time was that?
Sure, good question. Let me pull it up here just so I can be accurate. So he started with 16.2, no, I'm sorry. He started with 32.4 milligrams twice a day. And then for 4 days, went on to 16.2 milligrams 3 times a day, then 16.2 milligrams twice a day for 3 days, and then 16.2 milligrams daily. So,
All right.
yes. And for me, that was interesting in a sense that he was also taking the Keppra, and Keppra is induced, or the concentration of Keppra is lowered by phenobarbital. So I was wondering how much, utility the Keppra had in this scenario. A lot of times I see providers just kind of throw Keppra on as a safeguard, but I haven't really seen much evidence for that.
Other clarifying questions?
How long has this process been? You had mentioned the Keppra being written initially for 2 weeks, but from initial admission to now has been.
Yeah, good point. This, I believe, happened all the way back around the first week of May. So he's probably been in the hospital now for 3 weeks or so, maybe even longer than that. Yeah, I'm trying to find the exact date. But yes, so he's been through all these tapers, and just reading the addiction medicine doctor's note, it seems like he's still not to his baseline in terms of having kind of withdrawal from benzo. And it's possible now that, based on reading the note, that he's kind of developing some agitation, which could be related to the withdrawal or could be related to the Keppra. So this poor guy is going through it.
Other clarifying questions? Because I have one, if no one else has one for the moment. The taper that they started him on with Ativan, he's a 30-year-old gentleman who has long history of using short-acting benzos, and we just used a short-acting benzo for his taper. Does he have any other medical conditions? Like, does he have liver issues?
Yeah, that's a really good point. I was kind of wondering why we didn't use a longer acting benzo to begin with. He does not have any liver issues that I know of. When he came in, his AST was slightly elevated at 66, but nothing dramatic. Kidney function was fine. And the fact that he had successfully, come off of benzos on the diazepam in the past. I'm not sure if that information was known to the team at the time. But yeah, that's a really good point. I think, and the patient actually mentioned, I asked him, we were doing our group, and he was telling me about his experience, and he was saying, yeah, I'm wondering if like this IV short acting Ativan or IV Ativan is actually not helping me very much. And it was a good point. And I kind of said that in my experience, using a longer acting benzo for someone who's had such exposure to benzos may not be a bad idea to at least prevent some breakthrough anxiety and withdrawal. But I have also reviewed the literature that there's not a whole lot of difference in terms of success in coming off of benzos between switching between a short acting and a longer acting. But for someone who is using high doses, a longer acting could be just fine, I think. And it's probably a better idea.
Other clarifying questions? Anybody have any thoughts or suggestions for Aaron on this one?
I can jump in there. So at my detox facility in Georgia, I used to do a phenobarbital protocol for this type of patient. Actually, we did it universally for all of our alcohol and benzo patients. And our protocol was very different. Essentially, we would give them a loading dose of either 60 milligrams or 120 milligrams. And then we would keep dosing the phenobarb, I think about every 1 to 2 hours until they reached ataxia, slurred speech, or sedation. And so the doses would sometimes be, certainly as much as 240 milligrams, possibly even more. I can't remember, it's been a little while, in the first 24 hours. And then once you get that person to that level of fully saturated on the phenobarbital, then you taper them off over the next couple of days. What we found was that would essentially, that would cover a lot of the short-term anxiety. And I think it also provided a lot of protection for the seizure prophylaxis. So I would have never attempted an Ativan protocol on this type of patient. And I know other people who would have also used a Valium protocol. I personally have never done that just because the institutions I've been at didn't really use them. But I believe that my mentors that I've worked with have suggested that Valium protocols would also work for somebody like this.
Thank you very much. Yeah, I think we have a phenobarb alcohol withdrawal protocol that we use in the ICU. So when you were mentioning that, it seemed kind of similar.
Yeah.
And also like the front loading approach. Yeah, I think that would have definitely been a better idea.
And we were a non-ICU where we were doing it.
Mhm.
You really don't need to be in an ICU setting.
Okay.
As long as you're monitoring for those symptoms, the sedation, the ataxia, the slurred speech, and nystagmus. So as soon as you catch any of those, that shows you that that their brain is essentially, not saturated, but responding. And that's, so you kind of hit your threshold, and then at that
Right.
point you taper down.
Come down on
And
it.
we were a non-ICU. So at
Okay.
this point in time, honestly, I would probably still consider doing that for this guy, partly because of the protracted withdrawal. You might end up running into, I think, insurance coverage issues and things like that if you were to go backwards like that. But I would consider, because the nice thing about phenobarbital, it'll stay in their system for several weeks.
Right.
And in my experience, that was one of the few ways that you could get somebody off of a short-term benzo over the course of like a month.
Okay.
I mean, in the sense that you do the loading, and then 4 weeks later they still looked okay, is what I'm trying to say.
Gotcha. No, that's a really good idea. I think, yeah, if we continued, like now that Klonopin was started, if we kind of try to ride that out, he's going to be right back where he was when he came in. Okay, that's a good point. I'll mention it to the psychiatrist or the provider. Thank you.
I just want to add to this, one size doesn't fit all. And this patient should not be on a regular detox for the alcohol in general when it comes in evaluation. You don't know how much of it's 12 milligram reported Xanax plus the Klonopin, and the bottle of the at least wine was reported by the patient. I think the problem was from get-go, they did do the regular detox for someone who is drinking moderate alcohol. So, and we know that up to 96 hours after the withdrawal completely from the alcohol and benzos, means the last dose of the benzo and the alcohol was given, there is a chance of the patient having seizure and even DTs. So even though sometimes happens earlier, but it can be up to 96 hours after that. So I think that this case, as I said, it would be a good case to go to the M&M committee and make it some difference on the future of the facility.
Thank you. I think that's a great idea. I was wondering how we could take this case to kind of alter the detoxification protocol. I think a lot of times on the medical floors, we have patients in either alcohol withdrawal or benzo withdrawal, even opioid withdrawal, and they're not necessarily managed as effectively as they could be. So that's a good point. Thank you.
Any other recommendations or thoughts for Aaron on this? I do agree. It sounds like you guys may need an opportunity to evaluate maybe some protocols or just kind of how you're looking. I know this from reading this, not living this. So having Dr. Seaton comment on the phenobarbital protocol they used, very welcome, and thank you for providing that expertise. But some of the reading I've done, like the phenobarbital actually shows up real early in the process. So even evaluating that as part of your protocol. And this may be something that Kathleen can get back on and comment on, or even Tim or Cameron in our area. I don't know that we're seeing, I don't know if we're starting to use it more in our ERs or in some of our detox facilities around here in East Tennessee. Suzanne may know about where she is out in Memphis, if they're using phenobarbital in a protocol and bringing it in early. But from what I've been reading and hearing is earlier in the process, like even in the ER, getting the phenobarbital on, and sometimes even just a couple of doses early on seems to make a difference in how long a withdrawal course goes, what the patient experiences, and how long a taper of benzos following that may be required. So kind of in tandem, or even utilizing something like carbamazepine. So just, I don't know, just some thoughts along those lines of, there are other ways to go about this.
Yeah, definitely. I think carbamazepine has a lot of research to support it, but it's just such a messy drug. I think try to avoid it if possible. But in this case, I think it would have been indicated.
Well, and I agree with your comment about like the Keppra. People love Keppra, right, when it comes to seizures. So you see that used a lot because you don't have to follow levels and all that kind of stuff. It's a lot cleaner. We all love it as an anti-epileptic for that reason. But in this situation, it seems like it wasn't the right knife to bring to this fight.
Yeah, I agree, which is why I appreciate the conversation. Because I was, seeing everything that happened, I was like, I think we could have done things differently here. So I'll look into it, see what we can do.
Yeah, well, and this case also elaborates on what I think all of us are seeing is it's not single substance, single withdrawal. I mean, your alcohol and your benzos, you're seeing a very similar withdrawal picture, but I mean, 12 milligrams of Xanax plus some Klonopin, that's some pretty heavy duty benzodiazepines this gentleman's brain has been exposed to. I mean, the alcohol is kind of like, man, whatever.
Right.
Not to downplay that, but I mean, the amount of benzos he's being exposed to is pretty intense. And yeah, that Ativan taper was nowhere near. I'm surprised he got through 3 days, to be perfectly honest.
It was, yeah, it was not a great scenario. No.
So he is unfortunately a canary in your all's coal mine, calling out that adjusting protocols is warranted because patients are not coming to us, simple. It's not 1950s. It's not just a bottle of vodka that's happening a day. We got a lot that's going on in our patients' lives and a lot of substances to go along with that.
And not even mentioning like the new novel benzos that are out there on the street as well, which he did say he was purchasing Xanax, which, they're in pressed Xanax as it could be anything. So I suppose he is lucky he wasn't exposed to fentanyl and all of this. But yeah, I think I'll look into the phenobarbital protocols.
Any other comments or thoughts for Aaron?
Well, in the next few minutes, I just want to let you know that if you're looking at this case with the cost-effective approach, you also see that how much damage we made on the health system by doing extra work, and also having a patient that now has a seizure disorder as their one of the diagnoses, plus not being able to drive for 6 months until someone clear him completely. And I'm glad that he lives in a city that they do have a public transportation. Otherwise, he would be behind the wheel without the permission.
Right. Yeah. So many sequelae of just events that happen. Yeah, I agree.
Like I said, after you gave the case, this one's a yummy one. There's lots of stuff to dive into, which means, Aaron, you're now on the hook for a follow-up. So.
All right. Give me a minute. Give me some time.
Yeah, no, we got some time because actually, guys, this is our second to last session in this series. So we'll be taking 2 more weeks. We'll have our last session of the series. So please, everybody, be back with us in 2 weeks where we get a chance to talk about substance use disorder in adolescents with Skylar Geller. He'll be leading us in that discussion. So I don't think you'll have follow-up in 2 weeks, Aaron. As much as I would like for things to be, that quick of a turnaround, I don't think it will be. But we'll be coming back to you with our next series in August. So remember, have a good summer after we see you next 2 weeks. enjoy your summer. Come back and see us in August. We'll be doing this again. And maybe that will give enough time for you to have an update for us, Erin, because I'm curious to see what comes of this in your hospital system.
Sounds good. Thank you.
All right, good deal. All right, everyone, 2 weeks from now, we'll see you all again. As promised, Rick put some wonderful articles in our chat, so get a minute to copy and paste those somewhere. You can save them, or just come back in about a day and check under resources on our webpage, and they'll be there as well for you guys. All right, have a wonderful rest of your May 18th, and we'll see you in 2 weeks. Take care.